Good afternoon. Thank you so much for being here. I am Robin Axel Adams, the Program Manager for the Fairbanks Center for Medical Ethics. We understand that our internet is down, and so right now we don't have any people joining us online, but they might pop up all of a sudden. So as we get to the question and answer session, we will still be chasing after you and reminding you to speak into the microphone so that if Ball and West are able to join us, that they will still be able to hear the questions. We'll just remind you, please, to silence all your cell phones and your electronic devices. If you need to answer a call, please do leave the auditorium. There are phones that are located outside by the hall closet. And we also need to say that Dr. Leland has no relevant conflicts of interest to disclose. So it is my pleasure to introduce Brian Leland. I met Brian a year ago as he was an ethics fellow with us. Dr. Leland is a board-certified pediatrician who will complete his fellowship in Pediatric Critical Care at Riley Hospital for Children in June. He is passionate about the application of integration of ethical principles as they pertain to the management of pediatric population. He has a particular interest in deeply thinking about that patient and physician trust building and how that trust building can happen in communication. Brian is also an IU basketball fan, and I'm not sure how they're doing this year, so I don't know how you're feeling about how they're doing, but that will be discussed. Excellent. He is a native Hoosier. He's also a car enthusiast and a father of a delightful 11-year-old, so 11-month-old. That is a slight difference. They age quick enough. I'm so sorry to have aged him there. So, Brian, thank you for coming and welcome.
Alrighty. I'm super excited to be here. I appreciate y'all also being here. While I am in total agreement that cell phones should be silenced, I will actually, since I noticed the lunch and learn was occurring, invite you all to send a text to someone who should be here and let them know that they can attend the lunch and learn and nourish their belly, or they can attend the Fairbanks Ethics Lecture and learn about nourishing their soul. All right, so let us get started. I'm excited to tell you today all about an initiative that our Pediatric Intensive Care Unit has been involved with for the past 14 months and is still actively involved with. And we cannot do that without doing a couple things first. So I have a few objectives for our discussion today. We'll start by going over a little bit of the history of physical contact or touch and healing and its historical significance. And then we will transition for a little bit to talk about hospitalization and the effect that that can have on not only patients but their caregivers' spiritual well-being. And then we will transition back again and focus on the integration of physical contact, spiritual well-being, and the other positive benefits that occur between a hospitalized patient and a caregiver when we promote those behaviors, specifically highlighting the initiative that we've been working on in our ICU. Forgot to turn my page. Here we go. So before we move forward, let me make sure I clarify this right now. When we use the term caregiver, this does not define a medical team personnel. This is meant to refer to anyone who is the primary caretaker for the patient. And so traditionally we think of this in the pediatric world as a parent, but it certainly is not only that. And so you may have a legal guardian or an aunt who is the primary caretaker, or a grandparent for that matter. So keep that in mind when we use this term in the future. Okay, so if we talk about history of touch, this is not unique to human beings, right? So this is an important focus across species, and there was actually a really interesting study done back in 2010 where an observation of non-human primates was made, and they essentially just counted up how much time in an average day they spent grooming and touching one another, and ultimately that ended up being 10 or 20% of the day. And I will point out to you that 20% of a day is just shy of 5 hours. So I invite you to think about if every fifth hour for 1 hour we all sat in a circle and gave each other shoulder massages, how much better our multidisciplinary care might be. There is obviously human historical significance for physical contact and healing. So as far back as 3000 BC, and actually just yesterday online I read an article that was hot off the press saying Now they think as far back as 5,000 or 6,000 BC that there are Native American cave paintings that highlight a spiritual leader laying hands on one of the members of that tribe in order to draw sickness out of them. And then I don't know if anyone's familiar with this concept of the royal touch, but this goes back to the 11th and 12th centuries where French monarchs, and many of the French would argue it's Philip I, the English would argue otherwise, would be able to lay their hands on a commoner in order to heal them. And this picture, this is Queen Mary I, and this concept of the royal touch became really popular in the 15th and 16th century when scrofula was epidemic. And scrofula, for those of you who don't know, is lymphadenitis of the neck caused by tuberculosis. And good news for Queen Mary is that the natural progression of that disease was spontaneous remission, so she was able to defend her right to the royal touch. So if we come a little bit more recently in time, a very famous person in history was once quoted as saying, to touch can be to give life. Who is this? Seriously? No? Who is this? Right? Okay, so this is Michelangelo, who's obviously very famous for the creation of Adam and the Sistine Chapel. And then we transition even a little bit more recently to talking about physical touch in medicine. And immediately I think of the physical exam, which is a evaluation technique that a care provider uses to help guide a differential diagnosis. And I consider the physical exam, which requires that you actually touch the patient, to be the beginning of the healing process in a medical evaluation. So this gentleman right here, I want to make sure I get his name right, is René Laennec, and this is a famous French physician who was actually credited with the invention of the stethoscope, which is this telescope-looking device right here. Okay, so as I mentioned, we're going to sidetrack just for a short while to talk about hospitalization and the effect that that can have on spiritual well-being, and then we will reintegrate that concept into physical touch moving forward. So in order for us to talk about spirituality and spiritual well-being, we need to know what they are, right? So spirituality is defined as essentially deep feelings or beliefs or person's sense of peace, purpose, connection to others, and or the meaning of life. And I define this because I think there is a common misconception that spirituality and religion are one and the same thing. And although they are often closely intertwined, they are not identical. I will refer very much today about spiritual well-being, so I've defined that as well for you. And Mosley's says that that is a sense of peace and contentment stemming from an individual's relationship with spiritual aspects of life. So I think of that a little bit more simply and just say that spirituality is the health of a person, spiritual well-being is the health of a person's spirituality. And I bring this up because it is important that we think about the fact that arguably all persons have some degree of spirituality regardless of whether or not they have a religious affiliation. So, hospitalization. We know that this is an intimidating environment for families and for patients alike. And in the intensive care unit, which is the only place that I work at this point, this is the case to an even greater extent. And that is a result of the fact that the acuity in the ICU is the highest of anywhere that it is in the hospital, that there is a very real possibility of death, that we provide very invasive therapies as part of the way that we can care for patients, things like breathing tubes and indwelling catheters like central lines, taking it as far as doing lung bypass, which is what ECMO is. And ECMO stands for extracorporeal membrane oxygenation. There will be a quiz. And then I actually just the other day was thinking about what our team looks like when we come bed to bed doing family-centered rounds, and I counted up very casually and was struck by the fact that a normal day we have 11 people on the medical team for rounds, and that, as you can read, includes those people. And then I realized we didn't include med students, and there can be anywhere from 2 to 3 of those, so let's round it to 15 for the team, which needless to say is intimidating. So what does this have to do with spirituality, right? So we know that there is great literature that provides evidence that spirituality is fundamental in managing illness and crisis. So back in '98, there was a study where they surveyed hospitalized patients, and the number one factor for coping in that group of patients surveyed was cited as faith. And then similarly, since we mentioned that this is not unique to patients but to their loved ones and caregivers as well, back in 2001, Stuckey did a survey study asking loved ones of patients who were diagnosed with Alzheimer's how they're, managing and how they're moving forward. And universally, those caregivers and loved ones responded that they were integrating and increasing their spiritual beliefs as they moved forward to try to work through the process. So this is a problem because there is also evidence that we are not providing the very best spiritual care that we could be. So back in 2003, there was a huge national survey study of all pastoral, well, not all, but lots of pastoral care providers asking, how do you think we're doing about supporting spirituality and spiritual needs for patients, specifically children and their caregivers in the hospital? And ultimately, those pastoral care providers identified that they thought we were doing about 60% of what would have been ideal. I also actually just yesterday was looking through one of the articles that I either have or will reference, and they commented about the fact that spiritual beliefs were identified as number 2 in medical decision-making behind physician recommendation. So these are things that are really important for us to be focusing on. Okay, so let's now try to integrate all of these things and then reiterate benefits of physical contact between a hospitalized patient and their caregiver when we talk about a healing process. And then we'll highlight the ICU initiative that I was sharing with you previously. So this is what we all want, right? We all want to be loved. We want to be snuggled. We want to have our hair played with. This young man seems to be suffering from hair loss, and I empathize. The good news is the less hair you have, the more scalp you have for massaging. So we know that there are lots of medical benefits that have been well documented as a result of physical contact. And I think most of you, if not all of you, are probably familiar with the concept of Kangaroo Care, which is a nationally accepted care standard for newborn babies, where even from the very moment that a baby is born, the mother or father will place the naked child on their bare chest, having skin-to-skin contact. And actually, just about a month ago, an article came out reviewing incidents of sepsis in babies, and they were able to identify a statistically significant decrease in rates of infection for babies that received Kangaroo Care compared to babies that had not. I find that very striking. This isn't new news, though. So even back as far as the 1950s, as well as a study that I have cited here in 1986, we know that increasing tactile stimulation or additional holding on a daily basis can improve weight gain and shorten length of stay for preterm neonates and help with symptoms of gastroesophageal reflux as well. So what does this have to do with spirituality? Is there an association specifically between physical contact and spirituality? And the short answer, of course, is yes. So back in 2008, there was a really well-written manuscript by Chang that attempted to conceptualize what it meant in a care provision model to physically touch a patient, and ultimately identified 5 goals of physical touch for that patient. And one of those 5 goals was determined to be the sharing of spirituality. And I'll read this quote to you because I can't say it any better. Physical touch, hence, can convey spiritual meanings, where physical touch is considered a mode of connection between two spirits. I think this is highlighted in another study that Kathleen Mert did back in 2005, where she essentially surveyed parents of dying children in a pediatric ICU and said, what do you need from a spiritual support standpoint? And that the number one report was to maintain a physical connection with their child at the time of death. So I think this leads right into the fact that when you think about spirituality and or faith, that there are lots of practices that place an emphasis on physical contact between two parties. So things like baptism. Reiki, for those of you who aren't familiar, is a ancient healing technique where you channel energy by running your hands along a person and identifying areas of good or bad energy and either pulling off bad energy or giving good energy. Hakomi is a Native American spiritual enhancement healing process where you use different temperature stones and place them on a person. It's a form of massage therapy. Okay, so let us review really quickly what we just discussed. So we said we know that historically touch and healing are associated, and that we know that touch and spirituality are also very intertwined, and that we have identified that spirituality is integral to illness management and hospitalization, not only for patients, but for loved ones as well. So we have a very serious problem then, right? So in the hospital setting, physical contact can be limited. And again, in the intensive care unit, which is where I work, it is an even bigger issue. And for all the same reasons that it can be scary to be in the hospital, there can be barriers that prevent physical contact from occurring between those two entities. So patient acuity, fear from a parent of actually compromising their child's care by touching them or holding them. The difficulty, the actual technical difficulty of taking a patient who is mechanically ventilated with a breathing tube in and a chest tube and central lines and picking them up out of the bed and placing them into their parents' arms. And then one thing that I don't think we had thought about prior to initiation of this initiative that I'm going to share with you is this last point, which was we would all argue we care about this topic, right? And we want to support and make an effort to support this type of interaction between caregivers and the hospitalized patient, but that we all go about it a little differently. And invariably, as all of current medicine says, bundles and standardization is always beneficial. That variation led to inconsistencies that compromised our support for those types of interactions. So ultimately, I was concerned that maybe just by not having a standard approach to the way that we support these types of interactions, that we were negatively impacting spirituality in our hospital. And so the question became, can we improve spiritual well-being if we increase these interactions? So I hypothesized that if we were to implement an initiative where we standardized and improved upon the way that we encouraged and emphasized the importance of activities that required physical contact between a caregiver and their hospitalized child, that we could improve the spiritual well-being of that caregiver while their child was hospitalized in the intensive care unit. And importantly, that we could do this without a compromise in patient safety. So I had 3 study aims / objectives, and the first and foremost of those objectives was to demonstrate an increased spiritual well-being in caregivers in association with implementation of an initiative that I just described to you. The second was to identify and compare perceptions about these interactions that caregivers had both before and after implementing the initiative. And then lastly, as I had mentioned just moments ago, that we would be able to demonstrate that we could take on this initiative without a compromise to patient safety. We identified and defined patient safety as accidental or unplanned extubations, and this was for 2 reasons. One, because when we talk about safety, I think of sentinel events, things that are life compromising to the child, and 2, because this is a national safety measure for hospitals across the country, so it was I think a useful tool when we talk about patient safety. So enter Project ROSE. Project ROSE, as you can read, stands for Reach Out, Soothe, and Embrace. I have to tell you that Dr. Courtney Rowan and I sat down when we were talking about this initiative and came up with 10 different names. It was Project Hold and Project Touch and Project Reach, and none of them then would spell something out that was clever. And so I called my sister and I told her all the options that we'd come up with, and in about 40 seconds she goes, "How about ROSE, Reach Out, Soothe, and Embrace?" And I was grateful, but also very frustrated. I think if it had been anyone but my sister, I'd have been like, "Oh, that's awesome." Instead, I was like, "Well, I'll consider it." I also must point out right now that this drawing, which I think is the most beautiful illustration of exactly what we're trying to accomplish through the Project Rose initiative, was a freehand creation by one of our fellows that graduated last year, Janine Z. Chang. So a super big thanks to her. And this, officially became kind of the Project Rose logo, if you will. So I mentioned Lunch and Learn versus Ethics lecture, and I brought that up because I consider Project Rose Kangaroo Care for the soul. Okay, so how did we go about the actual study? We had a very simple inclusion criteria, and that was if you were a caregiver and your child was admitted to the intensive care unit, then if they were there for at least 24 hours, you were eligible for enrollment. And some might ask, well, why do you have to wait 24 hours? And the short answer for that is because the goal of this evaluation was to identify caregivers that we thought were at the highest risk for compromised spiritual well-being, and we have a decent population that are routine post-operative patients who might be in the unit for 8 hours, or asthmatics who are on continuous for 4 to 8 hours and then immediately transition out of the intensive care unit, and that wasn't the population that we were looking to assess. We did have a couple exclusion criteria. Number one was non-English speaking caregivers. The second was NICU transfers, non-accidental trauma patients, and in-hospital ICU readmissions. So the NICU transfer and in-hospital ICU readmissions, I excluded for the same reason that we excluded the less than 24-hour stay, in that our NICU transfers that come to us for ventilator training have often been in the hospital for 5, 6, 7 months, and that isn't the acute phase of an illness or a crisis, and same for in-hospital ICU readmission. Non-accidental traumas had to be excluded because of legal reasons limiting caregiver presence in the room sometimes. And then we did not have the ability to appropriately translate and have the resources to include our non-English speaking caregivers in this assessment. I want that to go away. There we go. Okay, so I broke this down into 3 phases. Phase 1, which was evaluation of current practice in our ICU. Phase 2, which was the formal rollout of Project Rose, where we introduced the initiative, had essentially a 2-month period to perfect the changes that we were proposing and implementing. And then the 3rd phase, which was the formal evaluation of the changes that we had implemented. And I'll talk about each one of these in detail here. So phase 1, which was a 6-month period where we evaluated current practice of the ICU and the effect that that had on caregiver spiritual well-being prior to initiative implementation. We had to figure out how we were actually going to accomplish that goal, right? And so we created 3 evaluation tools. A initial survey that we would give to a caregiver the first day that they enrolled in the study, a repeat survey on day 4, which would then be day 5 of hospitalization of the child. And I was fortunate enough to be able to get tied in with Dan Young, who is the lead chaplain on this study, and they had been working on a spirituality assessment tool, which was a standardized tool that chaplains would use when they would come and try to provide spiritual support for caregivers, and so that was implemented. And we created a standard referral process to our chaplains through a scale that I created and I'm calling the Spirituality Distress Risk Factor Scale, and I'll talk with you all about that. So the initial survey had 3 components: demographics, which are listed here for you. And then I said, all right, and I'm just going to include questions saying, how's your spiritual well-being? Good, not as good, and realize that probably wasn't the best way to assess that. And so actually looking into the literature, I felt very fortunate and was super excited that there is in fact a validated spiritual well-being tool that we were able to use. And this tool is called the Facet SP12, which is a 12-question survey for assessment of spiritual well-being. And I picked this one in particular out of a couple that we could have used for 2 reasons in particular. Number one is that I looked through a review looking at all of the different spirituality assessment tools, and this was one of only 3 of the instruments that would allow you to identify the state of a person's spiritual well-being at any one given point in time, which was really useful for when we wanted to track this measure both at point A and point B longitudinally. And then additionally, because this same tool had been used in what I consider a reasonably similar population, which was parents of children that were enrolled in palliative care programs. So this is what the FACET SP12 looks like, and I will point out one tiny change I had to make. So the original questionnaire reads, my illness has strengthened, and I know that whatever happens with my illness. And so I made the slight modification to reflect my child's illness, and initially I was concerned this was going to invalidate the tool, and so I actually contacted the FACET organization and let them know I was making that change, and they said not only did they not think it was an issue, but then they referred me to the fact that it had actually been used in a similar fashion in that palliative care study. So I feel good that it's still an appropriate tool to be using. Okay, so then the third part of the initial survey was those caregiver perceptions that I referenced, and I created 6 questions that I felt would help us to represent and identify how caregivers felt about the importance of these type of interactions, and then assess how we were doing as a team in promoting this / assessing it before we started the initiative to promote it. And so I'll let you read those really quick, but the short and quick is does this matter to you? Have you gotten to hold your child at all? Have you gotten to hold and touch him as much as you want? Do you feel supported in doing so? Anyone need more time? Too bad. So just for a quick reference, the FACET SP12, as you can see, is a 5-point Likert scale, and so I created this in identical fashion so that the survey would flow smoothly and be more straightforward for caregivers when they would fill it out. So that was the initial caregiver survey. The repeat survey, which was the one that was given on day 4, was identical. So we assessed those exact same things, but I removed the demographic information, and that's because the same caregiver filled out each of the surveys. So I referenced that we, very intimately involved chaplaincy in this evaluation so that we could try to provide the absolute best spiritual support and guidance that we could during their child's hospitalization. And this is that spirituality distress risk factor scale that I referenced. And essentially, as I mentioned when we were talking about inclusion-exclusion criteria, this essentially was a list that Dr. Rowan and I sat down and thought about for what criteria do a patient meet when they are the highest acuity in the intensive care unit. And we did that because we identified that if your child is the very highest acuity, then your caregiver is likely to be at greater risk for compromised spiritual well-being. And so these were things like having a bolt through your skull to measure brain pressures, to be intubated and mechanically ventilated, to be on blood pressure augmentation medications. And then obviously if the caregiver said, I need spiritual guidance, or a team member felt that they were concerned about it. And so this is an abbreviated version of the standardized Chaplain Assessment tool. And within each of these 7 domains, there were 1 or 2 questions that the chaplain would ask, and it was a free text guided interview basically with these 7 concepts, which were impact of illness, community, meaning and importance, hope, concept of holy, and then a plan of care and resources. And so when the chaplains would come and perform this evaluation, they would then de-identify the information and send it to us to a HIPAA-compliant data storage bank. And we will talk about analysis of that here. So that was phase 1. And I felt like we did a really nice job of kind of quietly going about enrollment for this, because I was concerned if we made a big deal about it that we might change practice just because people would know, like, hey, people are assessing whether or not we're supporting their physical contact. And so I think I use this word carefully, but deceived a little bit our medical team by saying we just want to make sure that caregivers feel like we're doing a good job in general. And for some reason they bought that, which was great. So this was phase 2, which, as I mentioned previously, was our official ROSE rollout. And essentially what happened was the very first day of the initiative, I sent out an email to every member of the intensive care unit. So respiratory therapy, all nurses, all physicians, social work, unit representatives, telling them about this and the changes that we would be making. And included in that email was a little 8-slide PowerPoint that highlighted the importance of physical contact and the effects that we think that it can have on spiritual well-being, and the changes that we are planning to implement. And I will go through each of these. So I put some posters up in the unit highlighting and promoting Project Rose, and rosebuds, which is a term I came up with to signify the opportunity for nurturing and growth, were little pamphlets that were included in all of the admission packets for caregivers when their child was admitted to the ICU, highlighting that we were taking on this initiative and that we wanted them to be actively involved. Baskets, I put little baskets that had items in them that in order to use them as a caregiver, it required that you would touch your child. So these were things like stickers and temporary tattoos and socks and hair barrettes and things like that. And then the biggest change that we made from a standardization process was this safe to hold question. So every day on rounds, when we are finished presenting an assessment and plan, we go through our safety checklist, which discusses DVT prophylaxis and can we change meds from IV to oral. And we added to the safety checklist the question safe to hold. And this was to identify if the patient was safe for unrestricted physical contact with the caregiver. So if it was a small child, that meant they could safely be transferred with the help of a medical personnel into the parent's arms. And if it was a larger child, then the caregiver could actually get into the bed with them. And if they were identified as safe to hold, we put a little magnet that had the Rose logo on the door frame. And if they weren't, then that would go in the isolation cart to be reassessed the next day. So here's one of the posters. This is the rosebud that I was telling you about that every caregiver got when they entered the unit. Here are our little baskets. Oh, and I forgot to mention this. So I also had lapel pins made with our Project Rose logo so that we could promote the initiative. And I didn't even think about this, but it worked out beautifully. I gave one to all of our nurses, and they were able to actually put them on their badges. I'm not sure why I'm highlighting that when I have this picture. Here we go. So which I thought was just awesome. Oh, and there's one of my posters half cut off. And then this is the magnet that's put on the door frame, always in the same place, right next to the isolation sign, next to the patient's room number. So that was phase 2, same enrollment process. The third phase then was very straightforward, where we continued the enrollment process, evaluating the changes that we had implemented during that pilot phase. All right, I feel like no matter what, after 35 minutes, everyone needs a break. I invite you to stretch your legs. This is my son. I promise when I play this, it will be right side up. I don't know why it's doing this. So my wife got, my son is Lucas, this little train for Christmas when he was about 8 months old, and this is his official first attempt at walking with it. I know it's upside down, but you can all tell, and since I'm an IU basketball fan, this was a gift not from me that I don't support.
Go, Lucas, go. Go, Lucas, go.
Oh, come on. Good job. Yeah, it's really fun. Oh.
So I don't know if we can turn this up just a little bit more in the rec room. I will invite you to listen really carefully, not to myself or my wife, but listen to the cackling baby, because he is enjoying himself. I know you can't see his face.
Yeah, come on. Yeah.
Go, Lucas, go. Go, Lucas, go.
Oh, come on. Good job. Yeah, it's really fun. Oh.
All right, good talk. So let's talk a little bit about the results, because I am very excited about them and can't wait to share and get your feedback after I get done moving forward through the pages. Here we go. Okay, so our pre-Rose intervention, which was a 6-month period from February through September, we identified 285 eligible caregivers and ultimately enrolled 72% of those. I will point out to you, because I think it is significant, that if we were actually able to find you and discuss this study with you, 89% of people were involved. For the purposes of analysis, because the intervention was occurring during both the pilot and assessment period, we grouped those two together. So this was 8 months, 2 months pilot, 2 months or 6 months assessment. And we had 300 eligible caregivers. And again, we did have a population that couldn't be found to offer enrollment to, but of 304, of 299, only 5 declined. So we had a 98% enrollment rate for the Project Rose initiative. And I think this just speaks to the fact that people care about this topic and really want to make an effort to highlight its importance. So the infamous Table 1, identifying whether our our caregiver populations were similar so that we can compare this information. And with the exception of household income, which I'll talk about in limitations, there were no statistically significant differences in our demographics. So here's where the money's at. Did we actually positively impact caregiver spiritual well-being? Yes, we did. Yeah, you can applause. It's okay. Or applaud. I said it wrong. Ruined it. So this table to break down for you is before the intervention, during the intervention, day 1 facet score, which is their spiritual well-being score, and day 4 score. So before the intervention, the increase was none. After the intervention, there was a statistically significant increase in spiritual well-being, specifically on day 4. So this was of no surprise to me. So I think some people say, well, you didn't show an improvement on day 1. I identify that to be expected. So this was, we're talking about enrollment at hour 25 through 32 a workday, and confusion and crisis and very few opportunities to embrace the support for these types of interactions, whereas by day 4, which was actually day 5 of hospitalization, there would have been recurring opportunities and exposure to all of the awareness and promotion for the Project Rose initiative. And so I am super excited to share with you that we were able to identify increased caregiver spiritual well-being at day 4. So I'll talk a little bit about the caregiver perceptions here, because I think this kind of solidifies the underlying principle for why we took this on in the first place. So this is some analysis done correlating each of those perception questions with a facet score. And I will just go through one of these to try to help explain it, because I think it's easier to do it that way. So remember, these are 5-point Likert questions. So hold frequency, that question was, have you gotten to hold and or touch your child as often as you would have liked to? And when we look at all the responses to that, if you reported that you agreed with this statement strongly or very strongly, then you were more likely to have, in a statistically significant way, a higher facet SP12 score, okay? So that was the case for thinking that contacting affected your spiritual well-being, getting to hold it all, how often you got to hold, that the team supported you, that you felt like a valued member of the team, and then I will clarify the acuity limiting because it's a negative correlation, which is what we wanted, because acuity limiting said, do you feel that your child's illness and the severity of it is limiting your ability to touch them? So we want them to say, no, I don't feel that way, which means it would be negatively correlated. So saying no to that would result in a higher spiritual well-being score, which is exactly what we saw. So the fact that every single one of these is statistically significant, I think, is super notable. Before I spoil the fun. So I think some critics might say, well, that's great, but that doesn't show that your intervention did anything. That just says that people that think this is important have better spiritual well-being. And I would say, I agree with you. However, we did actually do that evaluation. So we then analyzed those responses for the 6 perception questions, both before and after, or during, since it is still ongoing, the implementation of our initiative. And with the exception of contact and well-being, which I'll explain momentarily, we saw a statistically significant increase in the reporting of each of these values. So essentially, when we promoted it, then they identified it as more important and felt that they were getting to do these things more regularly. So hold frequency, for example, increased after we implemented the Rose initiative. The contact and well-being question is not statistically significant, which actually I think strengthens the similarity between our populations, because this is simply a question a question of opinion, which is, do you think that this matters? And we want the two populations to feel similarly about the importance of this interaction. Okay, so I know we talked about making sure that we could implement this intervention safely and without compromising patient care, and we were able to demonstrate no change in unplanned extubation rates before and after implementation of ROSE. Okay, so let's talk a little bit about a couple limitations. I identified 4 right off the bat. I'm sure as we complete analysis, there'll be a couple more. The first is excluding non-English caregivers, and I identify this as a limitation because of the fact that more likely non-English caregivers have a different cultural background and a different cultural perspective about the importance of these interactions. So we missed a pocket of the population that may have had useful and unique information and perceptions about these types of interactions. Secondly, I know I pointed out in our demographics that there was a statistically significant difference in the household incomes before and after implementation of the study. And what we had our statistician do actually was take each of the demographic variables and identify if there were statistically significant differences in the spiritual well-being of the caregivers based just on that demographic variable. And we did not identify in this caregiver population differences in the spiritual well-being scores based on household income. So I think this just helps to strengthen that the two populations were similar. Next, we didn't have cameras in the room or people standing like the hand hygiene police secretly monitoring how many times caregivers touch their hospitalized child. So we weren't able to record a direct observation of the physical contact events. I will, however, take us back to pointing out that when we did the evaluation comparing the report of have you been able to hold your child and touch your child as often as you would like to, that improved after we implemented the study initiative, which to me says that surely the frequency of those interactions was increasing. And then lastly, and I think this is an important point and one that is important, I think, and hope that we can work to identify this moving forward, is that there is not a established criteria for what I will call a meaningful difference clinically in a spiritual well-being score. So if I recall correctly, spiritual well-being in the intervention group went from 38 to 41 for their scores, which was statistically significant. But we don't know if that means they went from 4 on a 10 scale to 6 on a 10 scale, or if they went from mild to good spiritual well-being. And that's something that the FACET organization has worked to evaluate, and they do actually have, so FACET has tons of survey tools, and they have identified meaningful difference for a few of them. Unfortunately, FACET SP12 for our patient or caregiver population, that hasn't been determined. Okay, so let's go through conclusions and then a couple things about next steps, and then I'll have 8 minutes for questions, I think. So in conclusion, I'm excited to tell you that we were able to demonstrate increased spiritual well-being in caregivers after implementation of the ROSE initiative. Similarly, we were able to demonstrate increased caregiver perception of contact with their child, and based on the 2 questions about valued team member and support for the interaction, caregivers' perception of involvement in their child's care also improved during this intervention. And then of the utmost importance, we did not compromise patient safety doing this. So this is a patient that everyone who has worked on our intensive care unit is very familiar with, a young lady who had a long course and is actually doing really well. But this is exactly what we want to accomplish through the Project ROSE initiative. So I will point out, this is a breathing tube, this is a ventilator, there's a central line here, mom is holding, mom is smiling. All good things, right? So we continue the Project ROSE initiative as standard of care in PICU today. Every day for every patient, safe to hold is discussed. I would like to have a discussion about whether Project ROSE or a derivation thereof can and should become standard of care at Riley. I think that while the ICU patient population and caregiver population was a great population to focus on for the initial evaluation, that these principles apply hospital-wide, and there's no reason that we should limit the focus to intensive care unit. I did have a formal discussion with our cardiovascular intensive care unit team, and they are officially considering adopting Project Rose. The only other things I'll bring up are that we focused primarily on an effect on the caregiver from these interactions, and it would be really interesting to either retrospectively look and see during this intervention or move forward and do prospectively to see if we can decrease length of stay of patients or ventilator days, or if they are mechanically ventilated and intubated, do they need less sedation if their parent or caregiver is getting to hold them more? The last two that I'll mention, I know I talked with you about, we have this huge bank of information from the Chaplain Assessment tool, and that's going to require a really detailed qualitative analysis. And I don't know if Dr. Torkey's here, but raise your hand. Are you here? No. Yes? No. Okay. But she gave me a couple tools and is going to help me with that. And I think it's going to be really useful information. But as part of that, we talked about the scale that we use for the referral system. And I think the plan is that we will look at the spiritual well-being scores in that subset population, comparing them to the non-referred patients, and see if they actually do have more compromised spiritual well-being, and then see if their scores are even different or more improved in association with the intervention. Because if they are, then we really should work to see if we can validate this scale, because it would be an awesome thing to be able to offer up to hospitals across the country as a tool to say, hey, here's a study saying we only provide 60% of appropriate spiritual care, and here's a tool that can help you identify caregivers early that are at risk for having compromised spiritual well-being. So this is our Project Rose team. I don't do this jokingly. This is every nurse, every respiratory therapist, every unit rep, every social worker, every physician that is currently employed in the ICU. And I mean most genuinely that every person on this is part of the team, and that we would not have had any success with the intervention if we had not had the participation of each of these people. A very special thanks to Courtney Rowan. I'm sure that they're here. I just don't know where they are. Mara Nitu, Richard Gunderman, Karen Moody, and Maureen Hancock. They were my scholarly oversight committee and met with me what I'm sure they felt was far too often over the past 2.5 years. Genesis Thomas and Jill Mazurek, who are our research coordinators and did the lion's share of the work with enrolling and sending out surveys. And then Beth Moser, who is our statistician, and Dan Young, as I mentioned, was our chaplain lead. And then I must highlight that there was no way that we could have taken on this task if we had not been fortunate enough to be grant recipients from IU Health Values grants. We specifically were awarded a fund for the integration of spiritual and religious dimensions in healthcare. I am officially done. I invite questions, and I actually have prizes for anyone who wants to ask a question, because I have leftover Project Rose pens, which these are actually magnets, so you don't have to puncture your fabric, and this officially makes you cool at Riley. So how can I help? Do we need to pass around the microphone or whatever, or not? Yeah, why don't you just go ahead and ask your question? Can you clarify that question? I feel fine about it. I think that universal precautions exist for a reason, and in particular, patients in isolation, I think it is absolutely necessary. If they're not, I can completely identify and support the importance of that tradition. Intuitively, I would tell you you should be able to do it, but I think it is really important when we talk about infection prevention, and I don't think that we can probably justify saying this is an exception to that rule. Oh, here is your pen.
All right, how do you feel about holding versus stroking? Just
I
holding
guess,
a person.
Sure. So I identify physical contact as one group, and so I think they're both wonderful, and if you can hold the child, wonderful. If you can't, then you should stroke them. You should do whatever you can to maintain a degree of physical contact. I only have 5 of these, by the way. Sorry if you happen to be one of the latter people.
What was the manner that the surveys were handed out and then collected with the parents?
We physically handed them the survey and physically retrieved the survey.
Okay, was this done by you, or I guess who?
So it was either myself or one of our 2 research coordinators. Yeah.
Okay.
So and the way that we enrolled was provided a study information sheet, and if a parent was willing, then they would fill out the initial survey, which constituted informed consent as well. Yes, ma'am.
Well, I think this is brilliant. I wonder why it hasn't happened sooner. I hope this takes off and enjoins the staff at Riley to do it
We wondered that
completely.
as well.
So, bravo you.
Thank you so much. Perfect. I will repeat your question. Awesome. If they enrolled in the study, then yes. And so I will point out that we really made a strong put. So the question was too long to repeat. But the answer to the question is that yes, caregivers enrolled regardless of whether they had their child identified as safe to hold or not. But that, to reiterate, not safe to hold did not mean not safe to touch. And there is I cannot think of a single situation where a child cannot be touched. So even our kids on ECMO that are sedated and paralyzed, we promoted and supported families and caregivers being able to maintain any degree of physical contact with that child.
Were there any families that participated in the day 1 survey but then did not complete the follow-up survey?
Yes, so the question you heard because he has a microphone. Yes, there were families or caregivers that did not participate in the day 1 survey, or did participate in the day 1 survey, that then were not available on the 4th day. And the protocol was such that you had 36 hours to complete the survey, so we tried really hard to make it so that if you just weren't there for one day that we could still get you surveyed, but if you weren't in that window, then we weren't able to include that survey. Yes, ma'am.
When I first looked at it, I thought it looked like more that the rose that was drawn, that it was wonderful and it showed such great depth, because the white part looked to me like another rose under it at first. And then when I looked again, I could see the hands. So there was this double meaning that kept just speaking to my soul as you talked.
I would love to tell you that was intentional, and I will. I will tell you that was completely intentional.
Did you notice?
I did not, but I think it's just because in my head I had hands embracing a rose, and so I didn't think about the fact that the fingers intertwined actually kind of looked like a rose as well. I have one more rose if anyone wants to ask one more question, and then I have 2 seconds for actually what I consider to be a hilarious story.
Hi. I do not have a question, but as a former NICU, PICU, and CV ICU mom, I just want to say thank you.
You're very welcome. Thank you.
I also want a rose pin.
Before you walk out of here, I have to tell you this really funny story. So because it was snowing this morning, I'm on call this evening, so I wore scrubs, and I brought my suit and my tie, and Dr. Beardsley and I share an office, and I, at about 11 o'clock, went to get dressed and realized that I did not bring my suit. I brought my jacket. And so I say to Andy, I said, I need your pants. And without looking up from his desk, of course, he's like, oh, you're hilarious, Leland. And I was like, yeah, no, but I do actually need your pants. So the good news is that Dr. Beardsley and I are similar sizes. So Samaritan Award goes to Dr. Beardsley for loaning me his pants. I've decided that since he's wearing my scrubs, he's also on call tonight. Thank you all for being here. I really appreciate it.